Good evening, everyone, and thank you for joining us for episode 11 of season 4 of Doc Talks with Dr. Forrest Tennant and Friends. We have a special guest with us tonight, Dr. Neil Anand, and we're so happy to have you all with us. Thanks for being here. Dr. Tennant, go ahead and take it away. I know you have a boatload. Thank you.
Okay, thank you, Jamie. I'm delighted to be here, and I'm looking very much forward to hearing our doctor guest and our good friend Dr. Ibsen, of course. I have a dialogue, which to start off with and to follow up with. Uh, when my foundation started the arachnoiditis project, well, some 5 years ago, our goal was to bring treatment to every community, diagnosis and treatment of adhesive arachnoiditis to every community. But we've always had a secondary goal or idea or manifesto, if you want to call it that. And I wouldn't think I would need to even say it, but I'm going to. And as we go along, I think one thing needs to be very clear, and that is our goal, our mission, our mantra is that no person in America should die in pain and suffering. Okay? And I know that sounds so trite, but I don't hear many people talking about it. Okay? We've talked about it on this program. Do people still believe that? I think we're going to hear more about that later in the program. For our education today, though, as I've promised for some time, we're going to have to talk about the Epstein-Barr virus. I'm pleased to say that my book on it came out on Amazon yesterday, and the title is The Epstein-Barr Virus, a New Factor in the Care of Chronic Pain. Now, we've asked Amazon what's the cheapest we can put it on there for. It's $15. Get one and take it to your doctor. But here is my message. I've actually been working on viruses and pain for longer than even I hate to talk about. That's over 25 years. And it's been a very confusing journey, but it's all come together right now. And we're going to have a little education session on that because everybody with chronic pain has to understand the Epstein-Barr virus. Now, let's make a couple of things very clear right out front. Treatment and prevention of the Epstein-Barr virus is not a substitute for anything people's currently doing. Don't throw away your pain relievers. Don't throw away your wheelchair. Don't throw away your sleeping medication or your diet. Keep doing what's working. The treatment and the prevention of Epstein-Barr virus is to add on to what's already working for you or what you hope is going to work for you. So I want to make that very clear. We're not saying that any treatment that's being done right now should be discarded, denigrated, or thrown out. Okay, let's make that very clear. The second thing I want to make extremely clear, abundantly clear, is that the Epstein-Barr virus is not the cause of chronic pain. It is not the cause of adhesive arachnoiditis or complex regional pain syndrome or pudendal neuropathy. Its correct category is what should be called, which is new in medicine, a catalyst. A catalyst. What it does, a better term or a simpler one maybe, it's an expediter. Okay? What the Epstein-Barr virus does, we now know, is that it takes a risk factor or a precondition. And then if that person is stressed, biologically stressed, and I'm going to define that in a few minutes, biologically stressed, the Epstein-Barr virus is what we call an opportunist. It will reactivate. Now, its first activation was when it entered your body, probably when you were 1 or 2 years of age, maybe when you caught mono as a teenager or a young adult. You're going to hear the term reactivation. Now, that's confusing in itself unless you realize that this name, all these names, have been created not by MDs, not by RNs, not by clinical people, but by laboratory-based virologists primarily. And so consequently, they have given us a vocabulary that is foreign to us. Okay? For those of us in clinical practice and for those of us who are patients, we have a vocabulary that we're being forced to learn because it's now part of the lexicon and in the medical dictionaries. So we're stuck with a new vocabulary. And the first one that you got to know about is, besides catalyst, you've got to know about the term activation and reactivation. Now, activation of the Epstein-Barr virus means the first time you caught it. Now, 80% of the people on this planet catch it before age 2. You catch it when you have the sniffles when you're a baby. Now, a handful of people have their first activation when they're teenagers or young adults when they catch something like infectious mono. Bottom line is 95% of the people on planet Earth have been exposed to the Epstein-Barr virus before they're age 25. Okay? And so you've got activation is the first one. Okay? Now, the second one is when you have biologic stress and the virus decides to reactivate. Reactivation means that the virus has been dormant, okay? And the virologists like to say it's latent. Now, that's a foreign term to us. You really become a carrier of a parasite, okay? The Epstein virus is a normal parasite in the human body. We all carry it, and we carry it in the membranes of our throat and in our lymphocytes. Okay, we're carriers. It's a parasite. It's sitting there and it'll do no harm, maybe all of your life. But under periods of stress, I'm going to have to define that in a little bit more, it will do what's called reactivate. Okay, it's a new term, and everybody's going to have to learn it. Reactivation of the Epstein-Barr virus. Well, one real quick sidebar note. In our studies, there are other viruses that tend to be associated with the Epstein-Barr virus, things like cytomegalovirus, things even rubella, and now COVID, and some bacteria also seem to follow the Epstein-Barr virus like Lyme or Mycoplasma. But Epstein-Barr virus looks like it's the leader. It is the big gun. It's the virus that does you in. Now, we don't quite know where COVID fits in quite yet, but it looks like, frankly, as a secondary enhancer of Epstein-Barr to me, but that remains to be seen. Okay, so you've got activation when the virus first enters your body, but it can then reactivate later under times of biologic stress. Okay, now, and then it becomes a catalyst or a expediter. It's not the cause of your rhabdoiditis or your complex regional syndrome or your fibromyalgia or your carpal tunnel or your migraines or your irritable bowel or your pudendal neuropathy. It is a catalyst that has taken a condition you already have and activated the virus, and then you put the two together and then you develop the disease. This is a concept new in medicine. Patients will have to learn it, doctors will have to learn it, and but it's simple. It's like anything else. It's simple once you kind of get the hang of it. Okay, now let me define the term biologic stress for you, because let me tell you the bad thing about Epstein-Barr virus, reactivation, and autoimmunity. It's like diabetes. You can have it for years while it's destroying some of your body and you don't know it. It's a silent disease until you develop a complication or unless you test for it and find out you have it. Okay? Same way with diabetes and blood sugar. You can have a high blood sugar for years and you don't even know you have it until all of a sudden you have a heart attack or a stroke or a leg ulcer, and that's the way diabetes works. Same way with the Epstein-Barr. Okay, well, what you need to know is this concept of biologic stress. Now, what do we mean by that? That means that you have something that's happened to you that causes your hormonal system to activate and stay activated for a while. That means that your cortisone is going to go up. Okay, it means your adrenaline's going to go up. Now, every day, all of us have stress. We were in a traffic problem. We didn't pay a bill. Somebody's standing in our way. We face little stresses throughout each day. But that's not what we're talking about. We're talking about something severe enough to make your biology, your endocrine system, your hormonal system go up and activate. And unfortunately, you can exhaust that also. Now, let me go over again I'm going to kind of write them out. There have been some very interesting studies on these things, on what are the preconditions and what are the things that cause the biologic stress that seem to activate or reactivate the Epstein-Barr virus. Well, first off, a lot of you watching this have a genetic connective tissue disease. Okay, mainly Ehlers-Danlos syndrome, some Marfan's, maybe some, hypermobile spectrum disorder, but you've got a connective tissue disease. Now, we've known for years that a depressed immune system is part of that disease, of those diseases. So congenital, hereditary, connective tissue diseases, that's a major precondition, maybe the most common. Now, the second one is trauma. Okay. Now, what kind of trauma are we talking about? Just about any kind that makes your cortisone or your adrenaline go up. That could be an accident, falling off a roof, an auto accident, a domestic problem, a military injury. It could be sports, okay? And that injury can be to your head, your spine, or your skeletal system, okay? Now, what's interesting, and we're going to come back to this trauma thing in just a moment. Why? Because some people had their trauma 20 years ago, and all of a sudden it's their spine problem today, and they don't connect the two, but they're connected, okay? So trauma at any time in your life, if it's severe, may be something that activated or reactivated the Epstein-Barr virus and gave you an autoimmunity process that you didn't even know was there until you got the cancer or until you had the intractable pain. Okay, so those are the two biggies, the genetic connective tissue diseases and trauma. Those are probably the two big ones. Sometimes an infection certainly will do it. Even infectious mononucleosis itself could be that stress in your life that obviously put the Epstein-Barr virus on track to harm you. But it could be something like a severe pneumonia or a meningitis or a Lyme or a mycoplasma. Also, if you're born with maybe what we call an autoimmune disease like systemic lupus or Sjogren's disease or ankylosing spondylitis, perhaps one of those diseases. But the other ones I want to talk about are, first off, psychologic. Now, there's some other kinds of biologic stress that I want to call to your attention. And the big one is, believe it or not, severe psychological stress that lasts for a while can also apparently reactivate the Epstein-Barr virus. Things like what we call PTSD, which originally came out of the military and out of soldiers, but we now know it can occur, after something like a divorce, something like a terrible financial problem, a loss of a job, a death in the family. In other words, it's very important to know that certain psychological stress you don't get over it, but it stays around for several weeks or months, raises your cortisol, raises your adrenaline, exhausts your endocrine system. You can reactivate the Epstein-Barr virus on that basis. Now, there are some other causes that we don't see too often. Strokes are one. Strokes are terrible, and it's been well documented to have immune problems after strokes. It's a terrible trauma, if you will. Nutritional deprivation. Now, we don't see it in this country too much, but people who don't eat or they're starving for a while, certainly that's a problem. I'm sure that was part of the problem when they first discovered the sarcomas and lymphomas in children in Africa who had the Epstein-Barr virus. Nutritional deficiencies. Fortunately, in our country, we don't see it too much, but worldwide, we certainly do. Another one is fatigue. I want to talk about fatigue for a minute. A lot of people who have work day and night jobs, they're going to have to be careful. They're going to have to be careful of what we call affective disorders due to seasonal change. So fatigue. A person just can't have sleep deprivation and fatigue. Otherwise, that's also a biologic stress. Now, I know that's a long lecture, but what I want you to know is that we humans are very susceptible to this biologic stress, and we had no idea that this stress, we always knew it was bad for us. We knew we shouldn't have it. We knew we ought to get it under control, and we always saw some health problems following it. But what we didn't know is that the mechanism is probably reactivating the Epstein-Barr virus. That we didn't know. Okay? Now, let's go on with this here for just a moment on how the system works. Then I'm going to give you some clinical cases for a quick moment. Now, the way it works is this. You have one of these preconditions, you get stressed, the Epstein-Barr virus reactivates. So what happens when it starts to reactivate? What we really mean, and here the virologists again have given us terms such as switching from dormant to lytic and some of those things, but you don't need to know that. All you need to know is that if you let that virus get a hold, it starts duplicating, and the lymphocytes start carrying it around your body. And it also starts forming what are called autoantibodies. The autoantibodies, again, is a term that everybody's got to learn. It means that you've got an antibody that's not protecting you, it's eating your tissues, it's attacking your tissues. Now, be well apprised of what I'm about to tell you. Amazingly, the autoantibodies and the Epstein-Barr virus likes to attack the nice, soft, juicy tissues, like small nerve fibers, like your fascia around muscles, like your disc between your vertebrae, which are very soft, incidentally, like the arachnoid membrane, both in your head to give you the migraines as well as in your spine. And so the virus initially likes to attack these soft, fine tissues. And I guess I'm really not quite sure why, other than it seems to be the first target. As a matter of fact, in my studies, the first diseases that people recognize they tend to be either fibromyalgia or migraines or irritable bowel. Tend to be some of the first pains that you get with Epstein-Barr reactivation. Things like complex regional pain syndrome or arachnoiditis comes a long time later, after you've already had a lot of these kinds of things. So what is happening is that once you have reactivated the virus, it becomes a catalyst. It becomes an expediter. It's going to produce these antibodies, and the virus itself can invade your tissues. In other words, it can go right into your arachnoid membrane and settle right there. It can go right into your glial cells and settle. Go right into your small nerve fibers in your groin and settle there. So you've got both autoimmunity and you've got tissue invasion of the virus itself. And we don't know how to determine the difference yet in science, but we do know that both situations may occur. So now, two or three other things, and I want to close out by giving you how medicine, I think, hopefully will change and recognize how to deal with the Epstein-Barr virus reactivation and autoimmunity. The characteristic is that the main one is that it is asymptomatic. In other words, you don't know this is happening until this catalytic process and autoimmune process damages enough tissues to give you pain, okay? Or to grow a cancer or a tumor. So you don't know that anything has happened. So you can go from reactivation maybe 5, 10, 15, 20 years before you finally end up with a disease of some kind, okay? So Let me just I'm going to give you about, these are real cases, incidentally, that I've received in the last 10 days, inquiries into our foundation, and to give you some idea of how we need to rethink some of these pain issues. First off, I got a call or email, I forget which, but I did talk to the family. Some days ago, it was a mother, and her son, who was in his 30s, had to move back into the house because he couldn't work anymore. And she said, my son is in so much pain, he can't work. He's got shoulder pain, he's got stomach pain, head pain, back pain. Doctor, what do we do about this? The doctors don't seem to know what's the matter with him. Okay, well, he has what I like to call now multi-site migratory pain disease. That sounds to me like the virus may be hitting all these different tissues. Bottom line, he needs tested for Epstein-Barr virus reactivation and autoimmunity. Second situation, got an urgent call from a family. They said, our 20-year-old daughter who has EDS has developed a spinal fluid leak and pain in her spine. What are we going to do about it? Well, now in the past, what's been done, blood patches, surgery, psychological therapies. First thing you need is the Epstein-Barr test to find out whether you've got Epstein-Barr virus reactivation and autoimmunity. Third case, got a young woman who just delivered a baby. She had an epidural. And after that epidural, she started developing back pain. It didn't go away. So her doctors did an MRI and said, you must be leaking. I'm not sure they saw a leak. We're going to give you some blood patches. So they gave her a couple of blood patches and she got worse. And they didn't know what to do. So the doctors and the patient called me. And I said, yeah, you need an MRI, number one, but number two, you better be tested right away for this Epstein-Barr virus reactivation and autoimmunity. Okay. And the fourth one, I got a businessman, he's in his 40s, very successful, millionaire, woke up one day with a bad back, been well, been healthy. And he'd been to a lot of doctors, epidurals. And the reason he contacted me, he says, I don't want to have surgery, but that's all they're telling me that I can do. And I said, well, let's go over the risk factors. Guess what? He had had a terrible auto accident when he was about 20 years of age. He was in the hospital, almost in a coma for several weeks. Guess what? That was probably where it all started. Okay. Bottom line is these are 4 cases. And before surgery and before you jump in and blood patches and before you do these other things, and they may all be needed now, don't get me wrong, but you need tested, okay? And I can tell you some of the cases I just talked to you about, they all tested out positive, okay? So what I'm saying is that we know today need, before we jump to some of these treatments and some of these conclusions, we need to know whether that person has reactivated the virus and is walking around with an autoimmune process. I've given you the bad news, and I want to make it very, very, very clear to everybody that the Epstein-Barr virus is pretty easy to control. Okay? Simple. We've got several agents that'll keep it from further reactivating. We've got pretty good treatments now that'll keep your tissues protected and maybe kill, and then we've got some other good treatments to kill off the virus. In other words, the reason why I'm on my soapbox, and the soapbox is only going to get bigger, folks, we can control this virus, okay? In fact, you can put an element into your own pain care that's going to give you another 20, 30, 40% pain relief. So I don't want everybody to think that this is some terrible thing that is just going to make people worse. I've given you the downside, the bad side. the unfortunate side, but we have to discover how disease happens. But the good news is the Epstein-Barr virus is just a parasite, and you can put it back to bed. You can put it back in that dormant state pretty darn fast. And also, I think your local doctors are going to like this because, incidentally, if you do show that you have active reactivation, your early EBNA test is positive, you got reactivation, yeah, you need to take some antivirals, you need to be on some corticosteroids, but it works pretty well. In other words, everybody I know who is tackling their Epstein-Barr virus reactivation and autoimmunity is getting better pain relief, getting better function. Okay, so this is all really pretty good news. To hear about how it works and what have you, it is kind of awful to think that some parasite in all our bodies is taking us over. But the good news is you can reverse it. Everybody who's got chronic severe pain needs to take the test, needs to know what to do for both prevention as well as treatment, and go from there, add it to what you're doing now. You're going to have a better life, less pain, need less medicine. You're going to be far better off for it. So to me, this is the best thing that I've come up with for a while. With that, I see Dr. Ibsen sitting there just waiting to come in. Just can't wait to get on here. Okay, you've heard enough clinical practice. Let's get down to something more important. Mark,
Yeah.
you know a lot about our guest here.
Well,
Perhaps you could introduce him to us a little bit.
I would like to introduce Dr. Anand in a minute.
Okay.
But before we go any further, I would like to make a link between the opioid research tool devised by Dr. Lynn Webster and the punishment that patients have received because of that tool being misinterpreted. That is to say, people with adverse childhood events, if you've been sexually assaulted, all these kind of traumas that can happen in young people, they are now disqualifying people with these previous histories from getting pain treatment, and they are the ones that need it. So let's be sure and get this research in our pockets and bring it with us to the office. And if somebody says, well, if you had an alcoholic parent, or if you were molested when you were 3 or something like that, we can't give you pain pills because the risk of addiction is so high. And that is not true. That's not why Dr. Webster came up with it. So when we start talking about childhood trauma or psychological trauma, the good news about this is we now have a way to measure it. And we now have a way to say to those Puritans who want to say, because you're suffering, we're not going to treat your suffering. We're now going to say, we know a Dr. Tennant who's got around that. And we now know that there's a biological marker for this. And we're going to apply that marker, and we're going to advocate for ourselves even more than we've been able to before. So good news there, too.
Wonderful. Mark, just to go along with that and even throw out a little more hope, there's a laboratory in Los Angeles, probably the cutting edge scientists on developing antiviral tests. They've now developed some panels in which they've got the cytomegalovirus, they've got the rubella, they've got the COVID all together. The doctors, once they learn even how to use those, will even help us. The bottom line is that we're learning that these viruses in all of us do reactivate. And these, isn't it amazing that people who don't like opioids come up with a new reason why we shouldn't have them by the week? Yeah. Okay. It's unbelievable, Yeah. So
thank you, Dr. Tennant.
Which gets into maybe when you introduce Dr. Anand. He's picked up some data. This anti-opioid attitude, I'd like to hear. I know he's been collecting data and can pinpoint some dates and some things. I just, I came up at a time when people wanted pain treatment. People didn't want people to die in pain. I came up at a time when law enforcement worked with doctors. They liked doctors, and we all work together. Today, us doctors at the bottom, the top of the hate totem pole, I think, and right up there with patients. They don't like either one of us, but I want to know where all this came from. And then, again, what do we do about it? Anyway, you want to introduce?
Well, Dr. Anand is doing something about it, that's for sure. Yeah, he is my friend and colleague. We've been working together for 5 or 6 years now. He has discovered some of the most nefarious shenanigans happening in data management that you are going to be shocked by. Get ready to pick up your jaw when you hear what he has to say. And there's this company called Bamboo, which I like to call Bamboozle, and he's going to tell us more about it.
Yeah.
So,
Yeah.
Dr. Anand, take it away.
Oh, thanks. Thank you so much for having me here today. I really appreciate it. Thank you so much. I really love this program. And as I said to everyone here, and now even more people have joined, and there's so many people here today, that layout with the Doc Talks is wonderful. So thank you, Ms. Sanchez, and all the other people who've set that up as a repository for the knowledge. And the fact that you're also recording everything, and your story and everyone's journey over time is going to be great. You know, it's going to be like a time capsule for the future. So as we go through this tough time, and I have to say, I wanted to have a little levity. I said to everyone before, I wanted to tell a few funny stories about Dr. Ibsen and my journey together, so that, you know, people can enjoy a funny story amidst so much hardship for a lot of people in this country. But what happened was I got arrested. I'm a pain doctor from Philadelphia. Just for people who don't know, I'm a pain doctor. I was born in near Philadelphia, grew up in upstate New York. Upstate New York is a little bit like Dr. Ibsen said, puritanical. And what's interesting up there is it has a very unique culture and subculture, that area, that New England culture, because I grew up for a large amount of my life there and lived there for a long period of time. But I've lived through a lot of different parts of the United States, and each place is different, and each people have very different ideologies. And some of these people have gone through tremendous trauma. Like in New England, you know, they went through the witch trial. So when I was a kid in school, in public school, you know, we learned a lot about the witches and the American Indians and different cultures and things like that, because the Iroquois Nation was up there. So I have a very different thing, even though I was born in Philadelphia, and then I came back to Philadelphia. And I'm just telling you a little bit about my background. Oh no, before I went to Philadelphia, I went to college in upstate New York to a place called Rensselaer Polytechnic Institute, which is like a monastery of science. And it's like 90% male, 10% female. So, you know, when I was as a guy, I didn't like it that much. But a lot of intense science and a lot of computers. So that gave me a little bit of knowledge to help figure out what is actually going on with respect to pain management, how it's changed over time. I went to medical school in upstate New York, and then I went to, I wanted to do physics and radiation oncology, because I was very into physics and mathematics, but there's a very small number of positions in the United States. And even though I applied a lot of places on the coast, I want to live on the coast because I'm a coastal guy. And anyway, I didn't match in radiation physics, so I went into internal medicine at NYU. And while I was there, September 11th happened. So I was at NYU downtown. I was at the closest hospital to September 11th. I didn't see the plane fly in, but I mean, I saw the explosion, the second explosion, because the first explosion, I was in some breast cancer lecture there, and someone said they saw a helicopter fly into the building. You know, at those kind of speeds, you know, you can misinterpret anything. And you know, we activated that day, and then, you know, when the two towers came down, there was a lot of dust that came into the hospital. And there were a lot of casualties, a lot of people who had died that day, and it was just a very horrific day. But after that day, you know, I decided, okay, we're going to fight Islamic terrorism, and then I joined the military. So I joined the U.S. Navy. At that time, you know, they wanted an anesthesiologist, and I switched into anesthesia, and I came back to Philadelphia, and I trained at Jefferson Hospital, Thomas Jefferson University Hospital in anesthesia. I trained, the person who accepted me was a Dr. Valerie Armstead into the anesthesia program, and I trained under some famous anesthesiologist named Yugu Kang. And basically in anesthesia, you learn how to put someone asleep to suppress human consciousness. But also to get people through surgery, you want to get rid of their pain. So you have to kind of learn how to manage people's pain and how to suppress their consciousness with chemical agents. So I hope I'm not boring you too much, but I just needed to give you a little overground. So just so you
Tell us
understand.
about the day they came and arrested you.
Okay, yes, I will explain that. How do we take things that are subjective, right? Because the problem is from a computer point of view, pain is subjective, correct? You experience the world, or every human being experiences the world through their five senses. Does everyone agree with that? Pretty much, right? Everyone experiences the world through their five senses. And then we have memory or storage. And in that memory, we can store our experiences, right? Through our memory. People wanted to take those subjective experiences and make them objective. Does that make sense? So Sigmund Freud and some other physicians, and there were physicians who wanted to take our subjective experiences and objectify them and reduce them, a reductionist process, which is common in science, to make sense of the world, to organize the world, to use the scientific method to improve and discover what's causing certain things and make sense of the world. That's a scientific process. So what the U.S. government has done is basically they are collecting data. Every time you go on the computer, they collect data. They can break down all types of data in all different ways. And there's all different companies that measure your data. For example, Nielsen's they measure who's watching what TV programs, so they know what's a hit TV show. You've heard of that. Each time you get a coupon card on your, a CVS coupon card, right? And you buy shampoo or whatever, it's collecting data on you. Each time you go onto Facebook and you use Facebook, it's collecting data on you, right? What you like, what you prefer, what foods you like, what sexual orientation you might have, what people do you like listening to, what music do you like. It's collecting all this data on your phone, for example. It's collecting data on the phone. It knows exactly where you are at all times, and through the GPS, each time you take a photograph, it stores where that image came from. Now, with the prescription drug monitoring programs, what they're doing is collecting information on patients and what type of drugs they're taking, what doctors are giving them drugs, what controlled substances are they getting. They're collecting all types of fields of information. How often are they getting it? How many pills per month are they getting? How much MMEs per month is a patient getting? It's collecting all this data. It's collecting all this data that they consider objective data. And but pain is a subjective experience, correct? For each person, it's different. I think we can agree on that. There are different types of people, different types of genetics. We know red for example, red-haired people. It's a defect in, I don't know, the way they process melanin. But red-haired people will experience pain significantly higher than someone else. And for anesthesia, they require more anesthesia. Okay, we don't know why, but we think it's due to something, an MHC gene, but they're resistant to anesthesia. So the government is using all this data to classify people, right? Because now it has all this data, this objective data, and they want to classify people through this data. So what the government has done is to create scores on people and scores on physicians. And they've been doing that since 1996, since HIPAA. And they want to criminalize certain behavior. That way they can control kind of the practice of medicine. But they can't technically do that because there's a law against that. So they have to come out with a different way of criminalizing behavior and incentivizing behavior. So they incentivize behavior with, you know, evidence-based medicine. And they will pay for certain things and disincentivize certain things. And that's what's really happening in the United States. So what happened was, you know, there's insurance companies, which are really mathematics companies, right? Insurance companies take money, a premium, and they're supposed to spread risk. And so what's happening is that insurance companies, which are mathematics companies, and the US government, they're doing something called predictive data analytics. And we've gotten Freedom of Information Act documents that explain this. And the predictive data analytics takes that data and tries to predict human behavior, criminal behavior, antisocial behavior, and categorize people, kind of like a caste system. Like in an Indian caste system, and I know it well because I'm an Indian and my parents were immigrants, so I learned a lot about the Indian caste system. They, you know, separated people into 5 or 6 classes, and by birth, you could never change out of that class. There was no movement between the classes. And then you'd be classified, you know, as a high-level person or a low-level person, but there would be no individual movement between the classes. Now we kind of have a system that's classifying people through these social credit scores and these artificial intelligence programs. Because artificial intelligence is trying to predict, right? An artificial intelligence program, you know, and we've, you know, I can talk about it from a militaristic point of view because I was in the United States military, what that means, or how, you know, a certain algorithm might be trying to target a certain doctor or a group of patients. And we've been studying it for many years now. And this is a very serious problem because they're going after lots of doctors in the United States. They're disenfranchising a lot of doctors in the United States. A lot of doctors are losing their medical licenses throughout the United States. A lot of patients are being abandoned throughout the United States. So there's all these huge number of effects that's happening. And it causes a lot of, you know, unless you're a hardy person, it's causing a lot of mental trauma to a lot of families around the United States. So, you know, obviously we have to fight this. We have to fight for our specialty. We have to fight for healthcare. And, you know, that's why I give, you know, Dr. Ibsen and Dr. Tennant, you know, all the kudos because, you know, when I was a kid, I would read about a lot of great freedom fighting doctors. And, you know, one of them was Che Guevara. So when I was a medical student, in upstate New York. The Motorcycle Diaries came out. I don't know if anyone saw that movie, but you should see that movie. And I watched it in medical school, my first year of medical school, and talks about this gentleman, Che Guevara, he went around South America and Central America, and he had asthma as a child, and he had to fight asthma his whole life. And he went to a leper colony. In this movie, if you watch it, he goes to a leper colony and he won't wear gloves because he said, I want to touch human beings and I don't want them to be scared of me. So, and what happened was, he tried to fight, in his manner, right? Because he's not of our culture, but he's, of a South American culture, and he came from that perspective. And when I was, and doctors can have very strong perspectives, and what I feel positive about the future is that we have so many doctors with positive perspectives, like Dr. Tennant, Dr. Ibsen, Dr. Cheek, Dr. Clement, who's here today. Thank you, Dr. Clement, for being here. Dr. Lynch. I mean, there's a bunch of doctors I recognize here. And to me, what's wonderful about the situation is that when I was younger in the military, we were fighting a doctor, Dr. Al-Zawahiri, who was a doctor who, had suffered, and, he tried to attack the United States, and then we had to attack him back. But, we need doctors like that, doctors who have very strong will in the United States, people like Dr. Ibsen, people like Dr. Tennant, people like Dr. Cheek, who are the backbone of this independent doctor movement throughout the United States that is trying to research things so that we're not conspiracy theorists, to do things in the proper manner, to get Freedom of Information Act requests, go to the government, go to our legislators, use the legislative process properly to try to affect change. So that's what's
Thank
going
you, Neil.
on. Yeah.
Thank you. Tell us about your case. Where does it stand?
Okay, so my case right now, it's been going on for years. And the reason it's been going on for years is I had Ronald Chapman at first, and then, the government did all these things, so I didn't have money, I couldn't work anymore, so I lost him. So then they had to change the lawyers around. And now with my new lawyers, I have some experts. Artificial intelligence is very heavy in my case. I'll tell you, there's narcs care that's involved. The PDMP is narcs care. That's Bamboo Health. Bamboo Health, they measure MME, distance from pharmacy, how often patients go to a pharmacy. So they're involved. They're artificial intelligence involved. Timothy King is the expert, United States government's expert against me. He has his own artificial intelligence. He says I can take subjective things that are subjective, objectify them, determine what's criminal or not, use my computerized artificial intelligence system, and determine which doctor is criminal or not. Yes, and he's being paid handsomely to do that. HFPP, General Dynamics Information Technology, they have their own artificial intelligence system. Blue Cross Blue Shield, they have their own artificial intelligence system. They call it Star and Star Sentinel artificial intelligence system. So there's four or five artificial intelligence systems that are in my case, as well as now the government is sending their top mathematician to come into my case. So we're calling it, I talked to Norman Clement, and I said, you can take my story, publish whatever comes out of the trial and all the documents. He posts documents from my trial, but you know, we're calling it the battle in the city of Benjamin Franklin.
Excuse me, Neil, unfortunately, we're running out of time. We may want to have you come back, but can I close this out today with one question?
Sure.
What you're describing is not only, it's shocking. It really is. It is a travesty. And my question is real simple. Why? What is the goal here? Are we trying to wipe out people? Are we trying to wipe out doctors? Are we trying to save money? Why? What is all this about? We're spending millions and millions of dollars. What is going on here?
Right. It's like all right. I mean, it's like how, to me, like, for example, I view medicine as an art and a science. And arts advance, sciences advance and change over time. But what is happening is that there's a very dogmatic system now that is used to basically, I guess, punish the people who they think are bad, and then stratify society into good people and bad people. And then the bad people are punished and are supposedly rehabilitated. And it's a warning to other doctors. So that's what the whole system is. I think also, based on the documents I've read, and this is very important, what happened was there was a movement from different, there was a meeting in 2012 with Obamacare, and they developed, like I said, that healthcare fraud preventive partnership. And we have the documents from all that from the US government. We got it through FOIA and litigation. Those documents state that they want to use summary statistics and, you know, measuring outliers, basically, and try to eliminate the outliers, to save costs and to you know, kind of industrialize and scale treatment to, you know, reduce costs and industrialize and scale evidence-based medicine, you know, a type of treatment. And if you go out and veer from that treatment or that treatment protocol, then you're punished. So they kind of then basically, and even though they're the ones who push the fifth vital sign, the FOIA documents, we have the Surgeon General of the United States of America, Vivek Murthy, admitting in a document that I have and I can share with everyone here, that doctors were taught and trained that pain management, you know, opiate pain medication is safe, effective, non-addictive for pain. And we were taught and trained to treat patients with that. So if we were taught and trained to treat patients with that, you know, there's cases United States versus 11, and you can't go back and say, hey, we got to arrest now all the doctors because they're the cause of the opiate crisis. So we have a lot of documents, and you know, you guys keep fighting hard. I wanted to tell some more funny stories about Dr. Ibsen and our journeys together, but we can do that another day and another time.
Neil, thank you so much. We're out of time. We'd like to have you back and have you again. You've been through this war, and what you're talking about is some global scheme to do something in society, which I'm still unsure about and mystified about. Thank you so much. Our prayers are with you. We know where your heart is.
Thank you so much.
Wish you the best, and keep collecting data. You're the one person who's doing a lot of that. Jamie, again, thanks for a great program. Mark, thanks so much as always. We'll see you next week. Good night.
All right. Thank you so much.
Thank you, Dr. Tennant. Thank you, Dr. Anand. That was brilliant.
Thank you, Dr. Ibsen.
Thank
All right,
you.
bye. Bye.
Thank you.
Thank y'all.
Everyone, I want to let you know,
Thank
Dr. Norm had something he wanted to ask. If we could just take a moment to hear what he has to say, please.
I'm not
Dr.
going anywhere. That was fabulous.
Dr.
Well,
Norman,
I think
just-
that well, one of the things that Dr. Anand and I have been doing is really looking and really honing in on the mindset of the Justice Department and why these things are being done. And just to give you a brief, things that we've come across is that this is basically being driven by lawyers who want to promote their careers. It is easier to go after, let's say, you get a greater reward in your legal career, or get up to higher legaldom, as we call it, going after Neil Arnon, MD, than Neil Arnon in the hood. And there's and the higher up you achieve in medicine, the better the target is. So this is what they're doing is simply it's down to a game of targeting our success and the ability to use data analytics to manipulate these indictments and to manipulate convictions, because it's all dependent upon the ignorance, and that's not a bad word, the ignorance or the lack of knowledge, let's say, of juries and particularly judges and those sort of things. And it comes down to having good legal representation that will that has that understanding of the field of medical science and meshed with law. And that's where we've been getting beat, but that's where we're winning at right nowadays. And guys like, and so we need advocates, people who think outside the box. In other words, like in the I would say medieval days of the folks who were part of a stage that society went through, or European society went through, called the Enlightenment stage. And what we have in the Justice Department is a phase we call the counter-enlightenment. So that's basically, I'll just give you, I don't want to.
They're treating people like lepers.
But so and so. Yeah. Winners and losers that Neil talks about, caste system, and those are all that's in here. All that's in here. And most importantly, it comes down to assets. Mark Ibsen may own a great yacht, a couple of large land and homes all over the place. Well, he's a good target that we can go after, because we can use civil forfeiture, abuse civil forfeiture laws to come in and steal his money, throw him into jail. Can I say just one? We went to a horrific meeting that everyone needs to hear about. This was myself and Dr. Anand.
Yeah, I went to the FDA meeting, and I wish we could have talked about some of these things during my meeting. But yeah, I went to the FDA meeting, and there was a lot of NIDA was there, and a bunch of organizations. SAMHSA was there, so they had a lot of physicians there, and you were allowed to ask questions. And I asked some questions like, how long can a patient be on these opiates? And they said, as long as the patient needs. So they did acknowledge that. One thing they did, I asked talk about tachyphylaxis, and I said, describe overprescribing, and, talk about the predictive data analytics. They didn't want to go into a lot of directions. And one of the main issues I had with them is that they're pushing for methadone and buprenorphine for everyone.
Yes. And
people, you go look at the MME table for buprenorphine, go look at methadone, and methadone, it's I'm an anesthesiologist, I'm a cardiac anesthesiologist. I did the first heart transplant in Philadelphia in the team. I was the team that did the first heart transplant. So I know how to dose things to, keep people alive, and, at a small microscopic level. I can tell you methadone is a great drug, but it's very hard because what happens is it accumulates very quickly. It doesn't, yeah, and it was killing a lot of patients. And the government was telling, and then the doctors would get arrested for treating methadone or patients with addiction. And then at this meeting that we just had with FDA, they said, nobody wants to treat the addicted patients. Well, yeah, no. And I said, please talk about the 3,000 doctors you arrested, because that's why nobody's treating those patients who have addictions or what, and whatever issues that they might have, because you're targeting people who prescribe methadone and buprenorphine now. So, make up your mind and give us some clarity on what you guys are doing. And so that's also happened. And you guys should know about that because that was recent and it was a big meeting.
And it was horrific. There's one guy that we need to really take a look at. His name is Wilson Compton. He's the head of the National Institute of Drug Abuse in NIDA, and this guy is just way off the hook.
Dr. Norm, what was his name again?
Wilson Compton, and we just wrote an article. I just put up an article, and Red Lawhorn was just flabbergasted. In fact, I had to call Red Lawhorn and remove him and fire him from his retirement, and said, "Red, you cannot retire." After what and he laughed. He said, "Red,
one small thing you can do is to tweet or retweet or like, or articles that you like, share them. And because I'll tell you, now that we're talking about algorithms and computer, you can get your stories out if you just do these small things, which is how a movement can build and your message can get
right."
I know Dr. Gitlow pretty well, and I talked to Dr. Gitlow, and this date he was in the Rhode Island area. He's a very famous doctor. He was nationally ranked and nationally known for his treatment for pain and addiction psychiatry, I think. So he called me the other day, and he said that he's now out of the issues or troubles that he has, but that he was targeted and through this AI system, and because Dr. Tennant tried to help him and defend him, that the government was upset with that. So the DA has a huge part in this of what's going on, and there are a lot of agencies and now a lot of doctors that want to expose this
corruption.
to expose this corruption, so that people can get the care they deserve and need.
Dick Gitlow is one of the doctors that tried to help Dr. Clarence Riddell.
Right.
He's told us the horror story that they tried to do to undermine him, and eventually they gave him all his material back too.
And we know Clarence Riddell because he's in Philadelphia.
Mm-hmm.
So I know a lot of those physicians that they arrested in Philadelphia because they went in and arrested they had a task force here and they arrested a lot of doctors. So, and what's happening, it's a little bit more sinister that I think is really bad. And I'm trying to raise attention to that is some of these insurance companies, they're using these algorithms that are targeting people and they're profiting from reducing care or denying payment, denying treatments, denying coverage, and they're profiting from it. To me, that's just, give us algorithms. Tell us how you're doing that. That you should be able to tell us how you're doing all these things. And each time I ask them for that, or the U.S. government for that, I'm getting the runaround. Why? That to me is like, it shouldn't be. If you have algorithms, just share them with us.
Do you guys know about the Frontline COVID Care Alliance? Because they're fighting this battle on a whole nother front internationally with the WHO, trying to get individualized medicine, and they just put out a letter. But I keep thinking if we could connect, because they have won some legal battles.
I'm sorry, Julie, what was the name of that again?
The FLCCC, the Frontline COVID Care Alliance. And they're an alliance of amazing doctors, really high-ranked, well-published doctors from around the world that formed during COVID to come up with treatments. In fact, their protocol was adopted. But what they're fighting now is this, like the WHO is trying to, which isn't medical organizations, is coming out with ways to deal with future epidemics. They're not going to the doctors. They're trying to do away with individualized care, and they're fighting that. And I just keep thinking, can we connect with them? Is there politically some way we can align ourselves? Or it's a different front though. Theirs is more international, but it seems like
I'm sure they. Well, I'm sure they
have a website. You could look them up as a doctor. I'm sure they're open to talking to people. I mean, they have Zoom meetings every week I don't go to, but it seems like a really similar fight, just in a different arena.
The American Medical Association is trying also as well.
Yeah. So anyway, I just read their letter.
Association that came out with the new guidelines is supposed to be adapted by the AMA, saying, look, what we have done since 2016 has created harm. And what we're doing, we're seeing illicit fentanyl crosses, not a prescription drug crosses. So they need to change course. So they've adapted to new guidelines made up by the Federation of the American Medical Boards Association. So adapted came up with new guidelines, and the AMA is backing those new guidelines.
Yeah, but let me ask you,
the last,
what is the Federation of State Medical Boards? When they came out with updated guidelines in April, why are they not being followed by the state medical boards? That's something I don't understand.
Right, because you have different state medical boards that's composite, and you have medical board examiners.
No, this is the Federation of State Medical Boards. Isn't that and my guy, the guy that's the head of the state medical board here in Maine, he's on their list. So when I click on the state of Maine, up comes his website. So it's definitely the Maine Board of Medicine here. I'm just wondering if the Federation of State Medical Boards updates their guidelines, is that just a smokescreen for all of the other medical boards to say, look, we're going to do this, or do they actually have any power? And why wouldn't the state medical boards follow that guideline?
Because it's a lot of politics that starts from the top. If you would have gone to this FDA meeting that we, I wish everyone would have heard this, and I hope they will have another one. I mean, these guys are horrifically behind the times. They're into, for example, the thing that really alarmed me was Dr. Compton said that narcotic, well, he used the word opioids, of course, weren't to be used in any type of dental procedures or things like that. Then he recommended that we use Tylenol and ibuprofen combination, a combination that has been soundly rejected by the American Medical Association.
They're way behind.
Dangerous. Oh, God.
Because you see, like you guys here, you guys are sharing information, talking about states. You have many people here. You're sharing ideas. Each time you can bring a new guest. You guys are trading a lot of information. You're getting a lot of information. So you guys are so much. I mean, honestly, these people should come and talk to you guys.
Right.
No, I mean, if they were smart, if they wanted to fix the problem.
Our other days to hire me. I just want y'all hire a patient, get our perspective side of it, so then y'all know what's really going on.
Just how backward these guys are.
Yeah.
I wrote an article. It's called, and this is in Your Within the Norms, our last article. It says, how the 2019 study refutes CDC opioid guidelines, exposing the incompetence of and failures of the National Institute of Drug Abuse, NIDA, director Dr. Wilson M. Compton, MD. I mean, this master's degree. This guy, his knowledge, I swear, we kept asking,
Like the
what
modern
medical school did he go to?
Yeah,
This guy is so far behind.
modern wisdom.
Yep. And
The
everyone,
CDC daughter.
I would love to be able to
Yes.
continue this on for so much longer. We are 15 minutes over time, and we've
Oh, okay.
appreciated every one of
Okay.
those moments, but that's okay. We need these times. We need these moments. So I just want to let you know we got to wrap it up for tonight.
Okay.
I
Thank
hope
you
you
so
all
much.
come back
Good night.
next week. Please
Good
come
night.
back next week so we can talk more. I thank you all.
And
Thank you for every bit of this. And please make sure you do visit youarewithinthenorms.com. He has some fireball information out there. You're
Norman,
not
can you make a
alone.
story? Can you make a story
Yes.
about this?
Oh yeah, absolutely. You send me the video,
Norm,
it'll
can
be
you do
right there. Every week I'll put one about the progress
Make
of
a
this
story,
league.
Norm, for
All
us.
right.
Yes.
Yes.
And Dr. Neil, I cannot wait to hear a funny story about Dr. Ibsen, but I don't want to do that without him here.
You're right.
So
Yeah.
we'll
Yeah.
wait till
Oh, I have
he's
a
here
bunch of
again.
funny
Like, you
stories about
got
him,
it
but
out for
okay.
him.
Yeah, he's awesome. So I hope that ends everyone's evening with a smile. And we'll see you again next week. You're not alone. Thanks for being here. Good night.
Thank you,
Thank
Jamie.
you, Jamie.
Thank
you
you
all.
all.
We
love you.
Thank you,
Yes.
everyone.
Thank
I
you.
want to,
See
okay,
you, Dr.
thank you. And I
Wayne,
want you to
Dr.
know
Ron.
I put a link on every of this article. I see Ashley there. And Ashley, that article I wrote about you is all over the world.
Oh, how about that?
Thank
All
you.
over the world. All over the world.
God bless you, Jamie.
Norm, just real quick about the dental pain. That is such garbage. Having worked in oral surgery and dentistry myself, I just think that's cruel. But we can talk about that later.
This guy is just perfect. I just put a post, put the link on there. If you go to youarewithinthenorms.com, you'll see that particular article that we wrote on the CDC. And this was a 2019 study by Red Lawhern and Nadu that refuted this guy today. And this guy is the director. It's horrifying. And we're dealing with a hurricane down here, by the way. I mean, it's really coming down here. There's rain now. So
Yeah.
I'm in the midst of a hurricane that we got going.
Yeah.
Well, we thank you for believing in us, because we don't have many that believe in us.
Thank you for not being afraid of the storms. Thank you for not being afraid of the hurricanes that we go through on a daily basis. Thank you for standing up. If you guys didn't stand with us, we would be standing alone.
Yes.
Thank you.
Thank you.
Thank you, everybody.
Thank you.
Thank you,
Jamie.
Thank you, Norm. I love all you guys.
Valerie.
Good night. Love you.
Good night, everyone.
Everyone.
Good night.
Alive.
You.
Stay alive.
Good night, everyone. Good night.
Night.
Good night.
Good night.
Night. Night.